Platinum award-winning medical groups, Edinger Medical Group, represented by their Executive Medical Director, Matthew Boone, and Parag Agnihotri from Sharp Reese Steely, who you met earlier today. We have Phil Madvig from Kaiser North, and representing Southern California, we have Dr. Jennifer Polson. Thank you.
Okay, we just had a quick consultation about who's willing to go first.
We might as well just go in order. How about that?
And,
I'm sorry, Hattie. We decided we're going to do it differently.
and it turns out that Hattie's order and our order are the same, because we're going to start with Matthew.
Yeah, there we go. Okay, so it's getting late, so let me start off by saying slightly controversial to wake you up, which is I think the way we're doing things is all screwed up. Okay. And, you know, before you throw anything at me, let me give you some credentials of our group, and then maybe it will buy some credibility. So we were the first Gold Right Care Initiative winner in the state. We were the first Platinum Right Care Initiative winner in the state. This year we were, I think, one of 10 groups or so to get the IHA Excellence in Healthcare Award. And so hopefully that, even though you may not agree with what I'm going to say, or you may disagree with what I'm going to say, at least it will buy me some credibility for you to listen. We believe that we find ourselves in a very perverse world. We have a Right Care Initiative Award, which is a managed care driven award. We have an IHA set of metrics that are managed care. There's absolutely nothing on the PPO side, right? And there's nothing on the Medicare fee-for-service side, something on the Medicare Advantage side. And yet, our group is filled with patients that are constantly changing insurance every year. And what insurance they might end up in and what drivers to improve their quality of care may not be set by them, but may be set by their employer, depending upon which insurance they choose. And so, you know, I will give you the sort of perverse example of three, let's say, brothers. It's a hypothetical example, all the same age, all have diabetes, all have poorly controlled hypertension. One, his employer chooses a managed care product. One, his employer chooses a PPO product. And the other brother lost his arm in a sawmill accident and is permanently disabled on Medicare and happens to be Medicare Advantage. And the way the incentives, the public reporting, the drivers of care that are overwhelmed. I don't know how many primary care doctors are in this room that actually see patients, but it's a tough world out there. And the way that we deal with all those patients is completely different, and that's not the way it should be. You know, it's an interesting phenomenon that for most of you, I'm assuming Kaiser does this also, but has dashboards, whether they be embedded in their EHR or whether they be separate freestanding entities or what have you. You know, we've sort of all fallen prey to the teach to the test mentality. And so what appears on our dashboard sometimes is only people that really matter. And what does it mean to really matter? Well, it means that you're eligible for pay for performance or you're eligible for public recognition. And so we've rejected that concept, and I'll tell you why, and I'll tell you why I think it is a good thing. I mean, it sounds like it should be a really good thing regardless, right? But I think it will speak to maybe why we do so well in diabetes, and I'm going to tell you that everything I tell you in diabetes is true for everything else we do. So we step back and determine our own internal standards of care. And, you know, those three brothers, as an example, you know, in California, for example, for the Medicare Advantage brother, there is no quality reporting on his blood pressure. There is no Medicare star metric for blood pressure reported in California. And so he could have terribly out of control blood pressure, and the logic of that dashboard reporting may exclude him from coming to the primary care physician's attention. The PPO patient, he doesn't even appear on the dashboard because nobody's paying for him to be in the software. there's no funding for him. And there's no incremental financial reward for a group like ours, potentially, to pay the vendor extra to load all the data for that PPO patient when there's no either pay for performance or public recognition for doing a great job for that patient. And so then you have the managed care patient who for all kinds of things that really shouldn't matter in the practice of medicine, but were they continuously enrolled? Did they, here's my favorite, they lost a limb due to amputation from the complication of diabetes, but in 2014 measurement reporting year, that allows them to have, instead of an A1C of under 7, to have an A1C of under 8. So, which is, completely clinically contradictory. So we've sort of said, you know what, we're just going to decide what is the right thing to do. In this case, it's JNC8. It could be across all aspects of the care we deliver, and that's going to be our standard. And we're going to have, we can't rely on outside vendors who are teaching to the test. We're going to have our own internal reporting tool, and we need to put as much focus on all of our patients, whether they are patients that we receive pay for performance or not, and whether we get public recognition or not, or whether they've been continuously enrolled or not, or whatever. And so I think how does that translate? Well, like this year, we had #1 in optimal diabetes care in the state. Well, why does that help, or how does that help? Well, these patients, in our world, Kaiser patients are pretty loyal to Kaiser, obviously. But in our world, their insurance, they may be loyal to us, but their employers are not loyal to their health plan. And they're constantly changing. And it's really hard to say, this year it really matters that you get these things done. And next year, it doesn't matter. And then the following year, it matters again, right? And it's all about socialization. It's all about education. And we can't expect to provide optimal care if we can't have a consistent patient message with our patients year after year. And the second thing is that, we're trying to prevent long-term complications. What sense does it make where we're on and off in terms of how much emphasis we're going to place and the incentives that we're going to place in delivering optimal care? It makes no sense. So that's part one, which is, we've been on JNC8, although for measurement year 2015, for public reporting, it's not going to be on JNC8. But we said, you know what, we're going to do what we think is right, and we'll let the chips fall wherever they may fall. The second part of this, I think, these outcomes speak from really redesigning deliveries of care. So let me tell you what we do. So as you all know, primary care physicians, it's a tough gig these days, right? I think the last statistic was that approximately 5% of internal medicine graduates were going into primary care. It's the lowest paid of medical specialties. It's has the lowest professional satisfaction. And every week, month, year, we are being asked to click one more thing, fill out one more paper, one more prior auth. And the collective morale, I have 5 minutes to tell you the secret of life. The collective morale of primary care physicians is really poor. And so here's what we do. We tell our primary care physicians, you need to do we want you to do 3 things. One is, we need you to be diagnosticians. Number 2, we need you to be to have the relationships with the patients. And 3, we need you to provide cognitive input into dealing with various diseases, conditions, problems, what have you. So in our world, every single diabetic, whether they be managed care or fee-for-service, is assigned a diabetic coordinator, 100%. Okay? Now, what is a diabetic coordinator? Is it a pharmacologist? No. Is it a nurse? No. Is it an LVN? No. These are medical assistants that have been sent to specialized training to become super MAs in one particular specialty. And so we have 100% contact with all of our diabetics through our diabetic coordinator. Now, incidentally, I will tell you that we replicate this same pattern across every single thing. Why is that? Because, in so many organizations, they get a list. Here's the patients you need to work before the end of the year. Here's your patients that are poorly controlled. And it contributes to the collective morass and disgruntlement of our physicians. They can't do that. When you're seeing 24 patients a day, you have 30 messages and 40 labs. You just can't be working the phone, calling your patients saying, why aren't you taking your medications? And the spillover effect is that if you happen to pick a population of patients that was ripe for, attention, it would probably be diabetics, right? I mean, these are the people that are having the cardiovascular complications, and not just the diabetic complications, but all the other things. And so every refill flows through their diabetic coordinator. Every touch point flows through their diabetic coordinator. Now, I see your eyes, I see you pulling your calculators out and your eyes rolling, or not rolling, but spinning, because you're thinking, oh my God, let me do the math on this, right? Well, I will tell you that the name of our group is Edinger Medical Group. It's not the Sisters of Charity. We are a physician-owned medical group. We do not have a health system partner that we are a loss leader for, heads and beds. We are not owned by an insurance company. We have to justify everything that we do on a financial basis. And I will tell you that that particular endeavor, just like everything we do, has a return on investment. If nothing else, I would tell you this. If you're going to set a standard of care, there's only two ways to reach that standard of care. Either the physicians have got to do it, or you've got to have somebody helping them do it. And in our case, we have people that are trained to help them do it.
Great. Thank you very much, Matthew. Now we're going to delve into bravo, two sequence of Kaisers. We're going to start with Philip. You going to come up to the mic?
Yeah.
Okay.
Well, Matthew, I'm very happy that I work at Kaiser Permanente. Because really, I think many of the issues that so many people face are sort of invisible to us, which is it's a real privilege. I'm just going to spend a short period of time kind of continuing your discussion about how do you leverage primary care physicians and redesign systems of care so that we aren't in a situation where we have overburdened physicians who can't get the work done. So, what I'm going to cover is just quickly that we're moving from a way that we've been managing diabetes historically that we called a care management program, and we're moving instead to a population care program, and we're using a modification of our electronic medical record to support getting this work done. And this is historically what we did. We relied on primary care physicians to manage their own patients with diabetes. And then they had some help from a care manager for those patients who needed some extra help. And they would turn to those people temporarily and have them take care of that patient for a period of time until they graduated from that program, and then they went back to their primary care physicians. What we're doing instead is saying that the vast majority of patients with diabetes should be managed by an accountable population manager, and the primary care physician should be reserved really for those who need the most, need to really the benefit that they can offer them as their physicians. Of course, they all need to work together, but essentially we want to impanel nearly all of our patients with diabetes to either a nurse in the extended care role or to a pharmacist. And we need an electronic medical record support system to get that done. So it looks essentially like this. We start out by asking that our physicians give permission for their patients to be enrolled in this program. And essentially they're saying they're giving that permission for a period of 5 years. And as a result of that enrollment, those patients will be impaneled to an accountable population manager. They'll have their laboratory orders placed automatically. They'll have an automated outreach program that lets them know that it is time for them to get a test. And they'll go to the lab to get that test, and then that information will show up, as I'll show you in a moment, in the population manager's view of their population. If they get the test and they're doing well, then this system just continues to monitor them. And if they're not doing well, then those patients are brought to the attention of the population manager. who has a number of actions that he or she can take in response. And what it looks like is they'll see a screen that is like this, where each patient, we've removed the names, but each line is a patient. The first column shows their A1C value after testing. It's color-coded to draw attention to those who are in the greatest need of attention. And then the population manager can review these and get directly into the patient's medical record through this tool. And they can take action so that they'll see this screen that the patient is above goal and needs treatment, and they can take action off of this screen. That tells you the patient's preferred language, if there's a language preference other than English. And there's a little icon over here that when a primary care physician is looking at this screen, because they have access to this information as well, they can tell that there is an involved accountable population manager, and if they hover the mouse over that icon, they can see who that individual is. And then when in response, let me just show you, this may be subtle, but that color will change to that color when the population manager has initiated an intensification regimen, and now will indicate when the next test is due, and the system will automatically again order that for the patient. And then as a result of this, what we're keeping track of is how quickly do the population managers respond to abnormal laboratory tests by contacting the patient, by initiating an intensification regimen, and then how quickly is their therapy effective? Is it effective, and how effective is it over a period of time, which we've chosen to be 5 months to allow for intensification and for the A1C to have time to change. And then we can track our overall performance. And we can drill down in a fair amount of detail, and I'll just show you that here. Each line here would be one of the accountable population managers. You can see a number of things here. One is, what their testing rate is, what their success rate is. Here you can get an idea of how many patients they're managing. So they're managing in the range of 1,000 to 1,400 patients. And then you can see how quickly they engage in various activities and what their success rate is at 5 months after they've encountered a patient who has an out-of-range A1C. And success here is defined by improving the A1C by 1 point. And I'll just quickly mention, before Warren flags me for running over time, I'll just quickly mention that this is rolling out into all of our medical centers, and we're learning as we go, and we're learning what the optimum practices are, but it won't surprise anyone to know that these are kind of the key ingredients here, that there needs to be leadership to help people know that it's important and what we're trying to get done, and to bring it back to the idea that we don't want any of our patients who have diabetes to have a consequence of their diabetes that resulted from our lack of optimizing their care. We need a lot of communication among the team members, and they need to be ready to escalate treatment when the accountable population manager needs help. They need to know that they can get to the primary care physician. And we do a huge amount of looking at data and saying who's improving, how do we understand what it is that led some of these population managers to do better than others, and so that we can be really a learning organization, and over time learn how to do yet a better job. So I'll stop there. Thank you.
Now from Southern California, that's struggling a little bit more with diabetes management, we have Jennifer. I think it'll be interesting to everybody to understand how much of what we've just heard is system-wide versus area-specific.
That's correct. My name is Jennifer Poles, and good afternoon. I'm speaking on behalf of Dr. Cantor and Dr. Ho, who couldn't be here this afternoon. Our model is slightly different, even though we're integrated care systems. We don't have PROMPT in Southern California. We use a different system, POINT, and so that's where you're going to see a little bit of variation in the different work and different tools that we have in North and South. And I'll go over that a little bit with you.
So Jennifer is a very consistent member of our Los Angeles University of Best Practices, and thanks for coming up to Northern today.
Thank you for inviting me. When I was asked to speak today, it was not just about A1C and blood pressure and cholesterol, because you have those numbers in front of you, but more just the overall diabetes and how we approach care in Southern California. We look at it as complete care. So we measure everything that goes along with that disease states, from all the different complications to all their follow-up appointments. So I wanted to talk a little bit about that, because we don't just focus on the A1C goals or the LDL goals or the blood pressure. The culture that Dr. Cantor has set over the last 10 years, and it has been a journey and it has been a culture shift, is complete care, where it's every patient, every visit, every place. And that's why I think has been our biggest success, is that culture change, because we do get the specialists to get on board with this point of service, point of contact capture for every disease state, for every care gap. And you can see here we still struggle, but we're doing pretty well with retinal screenings, foot exams, just getting labs in general. Medication's a big focus. And so we look at everything, and a care manager is responsible for everything. It's not just the A1C. They actually do have over 50 measures, which also can be a challenge. We also team up with health education, because and this has been more of a recent change in our system, is complete care was almost siloed from health education. We're two separate departments. And so this year we've really been partnering, because what we found is a lot of times our nurses, our pharmacists, our MAs, our LVNs, we're spending a lot of time just going over education of the disease state, education on diet, insulin instruction, all those things. And so now we've really partnered with health education. We're trying to make more classes available in different languages and address some of those things in classes or group sessions or even online, so that when we see the patient, we can focus more on usually medication management and titration and move forward when we do see them. So these are the different metrics we have for diabetes that we really hold everybody accountable for, and from bariatric surgeries to, we have leaders in each one of these. There's a physician leader, usually primary care or internal physician, that leads each one of these initiatives, and they have algorithms and protocols, and they all group together to come together to basically put a strategy for the diabetic patients with all these items in mind when they treat a diabetic patient. And just as you heard earlier from Northern Cal, we do look at people, systems, and medications are our focus. So if you look at the people part, we have what's called the proactive office encounter, which is similar to PROMPT. It gives us a checklist of everything the patient needs while they're there with the care manager or the provider. We also have panel managers that do the touches for the patients who don't come into the office visits, that we can capture them. We also started this year, because access and the stress of primary care, we've really been trying to do phone appointments to give the primary care physician time to do phone appointments. Also for patients who work full-time, which is a lot of our population, it's hard for them to get in as often as we want to see them, so we do have phone appointments. And then our goal this year is 10 touches for every diabetic patient that's not controlled or has care gaps. So we're really pushing for more touches. And then again, we have champions locally and regionally that help the team members in their areas to be successful with all these tools that we have. And for systems, we have diabetes coding cleanup, after visit summaries, some epic changes so that the patients get the whole information from their visit into a printout that they can take home and review. We also have new technology that came this fourth quarter, where we can link up the Vario glucometers into Epic and get those readings directly into Epic, so those numbers can be used to help document their home sugars. We have IMI and health education, as I talked about. And another change this year is patient activation through what's called the patient personal action plan. And basically, it gives a very picture and friendly way of saying all the gaps that you have not completed that year, and it'll send you little emails that say, oh, you have an alert for your patient action plan. You are still didn't go to that diet class we talked about, or you still haven't picked up that medication we talked about. So all these different alerts that go into the system, and if you're signed up, it'll send you all the areas in which you as an individual can act on, and it'll tell you what phone number, it'll tell you what things you need to get done before a visit. So it's a very sophisticated technology that we just rolled out this year that can be accessed on your mobile phone, through kp.org, and it can give you reminders and help you walk through and navigate our complex system. We also, like many others, have physician reporting and also academic detailing for people who are struggling. We have pharmacy very integrated in this system. We have outpatient pharmacists that get printout with the prescriptions that say, this patient's due for diabetes labs, and please send them to the lab. There's an order already in there. It also has, this patient has not taken their metformin, they're 70% adherence, please have an adherence talk. So it's a very sophisticated system where it prints out so the pharmacist knows exactly what care gaps they can help when the patient's in the pharmacy. We also have MTM pharmacists calling and outreaching to the 65 and older. We have new member onboarding. We have additional meds that we added to the formulary this year, and I'll show you a quick slide on that. We also have reporting on med recon and adherence for all the medications, in particular for diabetes in this case, and we have outreach calls and letters for people who are less than 80% adherent. Here's our new formulary algorithm that we just added this year, so it shows you a little bit of our stepwise, because before we really only had 3 formulary agents, glipizide, metformin, and insulin. And we just weren't getting there with just those 3 formulary items. So we added 4 new classes to our algorithms this year, and we're hoping that will help us. So that's all I have for you today. If you have any questions, just please let us know.
Great, and now from Sharp, we have Parag.
Good evening, and first of all, I just want to thank all of you here who are still here with us. And all of you get 5 stars, and your names will be displayed on that board next year by Harry. So Harry asked me to again present, so I'll just share what Sharp Staley has been doing. And I think, rather than go through the whole thing, I just want to share 4 areas, which I want to share some of our thoughts on medical group's perspective on diabetes care. So the number 1, I think, is around patient engagement. Number 2 is around outcome measures. And 3rd is prevention. And 4th is technology. So first, when we look at patient engagement, you don't have to answer the question. Just for a respect for time, I'll just say, when we look at patient engagement and you think of this question, means the answer is pretty obvious. The number 2 is the answer, that we have to present ourselves as part of the care team. Means at 5 o'clock in the evening, number 4 might be also an option. But I think, when you look at everything, it's all about patient engagement, right? We will never get to where we want to be until patients are engaged in their own health. And the number 1 thing which is most important is how can we form the personal connection with the patient. And for personal connection, once we have the personal connection, then only you can do all these steps. And this itself is a big topic, but I think when we are dealing as a case manager or diabetes disease manager with our patients, you're not dealing with someone who is very compliant or easy to work with. You're dealing with someone who is very difficult, complex, non-adherent. You can use whatever term you want to use as a consumer, uneducated. So I think to do that, you really have to form a personal connection. So I think I'm probably going, okay. So I think I want to share some of the data from Sharp Staley on our population health program on patient engagement. And I think measuring the patient engagement is the secret sauce of everything. I think Dr. Milstein also spoke about the PAM tool, and that's something we use on an active base, on a pretty good basis. So here you can see clinic-embedded disease manager versus remote site patient engagement. The clinic-embedded diabetes disease manager have a pretty good engagement rate of 68%. Compare that to a chronic kidney disease case manager, who's a very good nurse, in fact. But just because of space issues, she cannot be at the co-located with her nephrology team. And her patient engagement rate is pretty low, her teams. And it's the point I'm trying to get to here is that the closer we are to the PCP, the closer we are to the treating provider, the better it is. And as we go in the era of ACO or a healthcare, different kinds of model, I think I request that the groups be or the providers be delegated for the care management or disease management activity rather than hiring a third-party independent people from Texas. So I think this is a very telling sign of how things go. The number 2 point I want to drive around is hitting the targets on process measures versus measuring outcomes. And I just want to share some of the studies, the references on the bottom. But from the 3 target studies on diabetics, which looked at the bundle of A1C, blood pressure, not smoking, LDL, and these are real-world studies, randomized controlled trial. These are not your this thing. RCTs, 77% of patients did not hit targets for 4 outcomes. When we look at cardiovascular disease, again, real-world studies, 50% got an actual target of LDL of less than 70A. When we look at IHS last year's 2014 data, on which a lot of this is based on, for optimal diabetes care bundle, you could score a 50th percentile rank if you had an optimal bundle care of 32% only. The 90th percentile is around 48%. The point I'm trying to make is clinically, we are not hitting those targets, but do they really matter? As a clinician, if a patient who's well managed, who's doing well, are you really going to make a treatment change for someone whose LDL is 101 versus 99, or A1C is 8 versus 7.9, or the A1C requires 2 A1Cs in 12 months period versus 11 month 29 days versus 12 month 10 days. Small clinical deviations do not, they don't have any clinical importance. In fact, we should be focusing on outcomes. And all of these studies, the outcomes improved even though they didn't hit the target. So when we look at Sharp-Resteli, I think right now we, as a medical group level, when we look at all the bundle diabetes, the optimal diabetes care bundle, the rate at Sharp-Resteli is 56% control rate. I'm just illustrating one of the sites here, but overall, there is a 56% process measure control rate. But I think the most important is how do we really measure clinical outcomes? And we know from published data that you need almost 82 to 150 diabetic patients to be in control to show a reduction in 1 MI, 1 stroke, or 1 retinopathy. And even if I take a conservative cost estimate of $20,000 per admission for MI and stroke, and we know that's not, we know that a stroke patient may cost $90,000. Using that as a reference, we did some trend analysis, trends for our population, and did 6-year trend look back. And we have seen that for every complication, retinopathy, myocardial infarction, and stroke, there has been a decrease in the complication rate. The dialysis also, I think it's just a rate, but when we did, I think it's, clinically, it takes 20 years to blow out your kidneys. So I think if we, continue to study this for 15 more years, we will be able to see some difference in dialysis. And if I just did some, cost estimate, just based on the rate last year versus this year, overall, this program, Diabetes Advanced Perfect Care Program, which is bundle program for 5 years, has shown a cost avoidance of $22 million in the group. Now, it doesn't mean that that money came to me or to the group. It went to someone as a purchaser